we did. We interviewed half of U.S. hospitals, approximately 2,400, and asked them about the availability of psychiatric services in their hospitals. My name is Dr. Luc Jensen. I defended my thesis on medical psychiatry units a month ago in the Netherlands at the University of Rotterdam. And I'm here with Dr. Roger Kedel and Dr. Van Schijndel. Perhaps you can also introduce yourselves.
I'm Roger Kedel. I'm an internist and a psychiatrist, actually, who lives in Minnesota and practiced in Minnesota, but also University of Iowa for a number of years, and have been involved in integrated care through the majority of my research and clinical life.
So my name is Mike Van Schijndel. I'm a psychiatrist in the Netherlands, and I do scientific research on integrated care, and especially on medical psychiatry units.
And we're here to discuss our paper today with the title Specialty Psychiatric Services in U.S. Emergency Departments and General Hospitals, Results from a Nationwide Survey. And we did this with a interview contained 7 questions, and the first 2 aimed to examine if these hospitals had a so-called medical psychiatry unit or a complexity intervention unit, a unit that integrates medical and psychiatric care. And what we found after surveying 2,400 of these hospitals is that most of these hospitals are lacking psychiatric services.
So I think it's a great introduction and takeaway, Luke. And I wanted to add that this study is part of a larger study into all U.S. complexity intervention units that are also known as medical psychiatry units.
From my standpoint, the main finding is that there is really a lack of psychiatric services in medical settings, both in the emergency room and in inpatient general hospitals in the U.S. And that's a major problem because 70% of patients with mental health conditions never go to the behavioral health setting. And without services available in the medical setting, they have really no options. And that's one of the reasons why the cost of care for patients that have mental health symptoms is double annually. There are a large number of patients that absolutely get no behavioral health care at all. And as a result, they go to the medical setting, to their pulmonologist or their GPs or their GI doc, and they just get tests and procedures and et cetera, and really don't get the critical component of care that would lead to outcome change of both their behavioral health and their comorbid medical conditions, and that is addressing the mental health issues that patients are presenting with. And I've worked in this area for now 20 years, and there's been little change. And the reason there's been little change is because you always come back to money, and behavioral health services are paid from a separate pot of money. And as a result, the people that pay for behavioral health services absolutely force behavioral health professionals to work in the behavioral health setting because they don't want to have to pay facility fees on the medical side. And so there is no service availability on the medical side for mental health conditions or substance use disorder conditions. And so we really need to create a way in which behavioral health specialists can actually practice in medical settings. And you've done a great job in the Netherlands with your national initiative to have med psych units in every hospital throughout the Netherlands. We need to do something similar to that, but it's not just med psych units, it's consult services, it's outpatient services, and we're doing a better job with collaborative care. The collaborative care model puts behavioral health professionals in the medical setting to help the GPs and other medical specialists address behavioral health issues. The interesting thing about that is that in order for those to be set up, there actually has to be a payment from the medical side, which is not part of the behavioral health, and not a part of the medical system. And therefore, a lot of programs are not set up because they don't know how to pay for behavioral health professionals working in the medical setting.
There's also diagnostic overshadowing. So that means that if you have symptoms, it's not always very easy to tell whether these symptoms are straight medical or straight psychiatric. So I think there's a big reason to evaluate together behavioral health services and medical services, or like you have in the US, double-boarded physicians that can assess both dimensions actually of biopsychosocial way of assessment. And then, of course, stigma that works in a lot of directions. One of those directions is that it causes some physicians to wrongly allocate symptoms to either medical or psychiatric illness. So, for instance, we have diagnosed a couple of patients that appear to have pulmonary embolus, but at first were thought to have an exacerbation of their post-traumatic stress disorder, PTSD. So, and patients themselves, and I'm not sure what the situation in the US is, but also there are some of mine patients, for instance, with schizophrenia or bipolar disorder, so severe mental illness actually, that have trouble accessing medical care. And this is for a part, this is the consequence of stigma, but also of a lack of tolerance of the medical system for behavioral issues that these patients have. So I think there are a lot of reasons to normalize integrated assessments in a medical setting to improve their outcomes, and also the high mortality that this combination of disorders is associated with. This article shows that it's not only the comorbid patients that end up in a medical setting, but also straight psychiatric patients that don't get the right care in the US.
Well, thanks. Yeah, Roger, in your previous answer, you talked about money, and of course that is often an important subject also in healthcare. And I think money also relates often to organization. And with our research team, we have a combined team of Dutch and US experts in this field. And I think one of the findings of our research is the difference in organization between these countries.
A difference between the US and the Netherlands is the availability of good psychiatric services, because in Netherlands we do have a lot of those. But the accessibility is also a problem in the Netherlands, because there are many patients that don't arrive at these institutions either because of they are too complex. So there's a large discussion in our media right now that our system takes care of the non-complex patients rather than what they should do, focus on our complex psychiatric patients that have multimorbidity, both in a psychiatric way and also combined with medical problems, of course. We have a system, there's also that's also segregated. So the mental health system is separate from the physical health system. But our hospital psychiatric care, I think, like Roger said, is a bit better organized.
Yes, the way that it's set up is critical, and the interaction of medical and behavioral, both clinicians and the administrators that pay for the services need to understand that the majority of psychiatric patients actually seek care in the medical setting and allow access to behavioral health services where the patients show up. And in the US setting, that doesn't happen.
I would like to discuss two things. One, for the short future, what's in your opinion is the thing that should be changed at a short notice, and what should be changed on long-term notice? And also, what can we or should be done within the field of research?
There are now at least 12 integrated approaches to medical and behavioral health care that show not only improved outcomes for patients, but also cost savings. 12. Most people don't know that. Most people concentrate on collaborative care, which is probably the best studied. There are a variety of programs that now have demonstrated clinical improvement and cost savings for the system. And that's sort of the short term thing. And the long term is now changing. You know, you've done it in sort of an indirect way, paying for behavioral health services in medical settings. Our behavioral health payers are so adamant against behavioral health services being provided in the medical setting that we really need to integrate the behavioral health system, payment system, so that the clinicians can now work wherever they want. The behavioral health clinicians, psychiatrists and psychologists and et cetera, can work both in the medical setting and the psychiatric setting.
There's a lot of overlap between medical and psychiatric symptoms, but also illness. About 25%, and in some populations, a lot more of inpatients do have behavioral health problems, substance use disorder, or psychiatric disorder in general. And if we could change this, it potentially saves us a lot of money while improving outcomes. And that would be a very good thing if we succeed.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.